virus cannot synthesize DNA from DNA, and there will be no further application of the virus. This is how these drugs acts. Now, this is common for all, so we are not going to discuss it again and again. Now, let's come to the prototype drug of herpes. You all know the name ACYCLOVIR, very commonly used in treatment of varicella zoster and herpes zoster. You can see here the bioavailability of acyclovir is very, very less, only 20%. And there is very, very low plasma protein binding and high volume of distribution. So the thing is that because bioavailability is less, high doses, acyclovir is given in very, very high doses. Second thing is because of low plasma protein binding, the duration is less. So it should be given very, very frequently. So for treatment of herpes zoster, you won't believe that the 800 mg 5 times a day for 7 days is the dose for acyclovir. And in government setup, only 200 mg tablet is available. That is 4 tablet 5 times a day. That is 20 tablet per day. You need to give that too for 5 days. If you are giving, you need to give 100 tablets to the patient. And the compliance issue is big issue because of this. So this is a practical problem we see when we treat patient of herpes zoster in government setup. Otherwise, in private, acyclovir 800 mg tablet is available, but that too is not very convenient to take because 5 times a day you need to take for 7 days. But yeah, it is very effective. And the reason for this is this pharmacokinetic which we are just discussing. It excreted in urine unchanged. So obviously it will lead to some renal impairment, or the patient with renal impairment need dose adjustment with acyclovir. TF is 2 to 3 hours, as I said, 5 times a day you need to give. But the results are very good, and the outcome is very good with acyclovir. Primary and recurrent genital and mucocutaneous herpes is one of the indication. Encephalitis, viral encephalitis, keratitis, herpes zoster, chickenpox, in all these conditions, acyclovir is used. Adverse effect are as such, it is very safe drug. Less adverse effect you can see: nausea, vomiting, diarrhea. The GI side effect, which is very common with all the drugs, stinging and burning sensation. If you are using acyclovir topically, basically this is not the adverse effect of the drug, but it is the adverse effect of the route which we are using. Apart from that, the peculiar toxicity of acyclovir is neurotoxicity, seen in only 1 to 5% cases with these symptoms of headache, tremor, behavioral change, delirium, seizure, coma. And mostly it is seen with the IV parenteral use of acyclovir, not with the oral route or topical route or any other route. Nephrotoxicity is also seen with the parenteral route. So it can show the symptoms and sign of crystalluria, hematuria, and renal insufficiency. There is no teratogenic potential, so it is safe in pregnancy. Now, so to overcome the deficiencies and disadvantages of acyclovir, we made valcyclovir in the lab, which is a prodrug of acyclovir. Acyclovir is itself a prodrug. Now, velyl ester is added to the acyclovir and make it velyl ester acyclovir, which is known as valacyclovir, right? So it again a double step activation required for this. Advantage of acyclovir over acyclovir is that the bioavailability significantly increases from 20% to 55 to 70%. This is very, very good. So obviously the dose frequency decreases and the more than 3-fold higher plasma level of acyclovir are obtained. So that's why this valcyclovir can be given in place of acyclovir if the patient is not compliant with acyclovir. 1000 mg or 1 gram thrice a day can be given. So this is one thing which is very important, and very rare toxicity which is seen with acyclovir is TTP and hemolytic uremic syndrome. But you remember TTP-HUS with valacyclovir. Then come panciclovir, which is a ester product of panciclovir. So you see panciclovir, famciclovir, all are those drugs which we already seen, and the mechanism of action we know. These are the drugs which are dependent on viral kinase for their activation. So the resistance to these drugs are now developed, and hence we have other drugs which are not dependent on the virus specific enzyme. T-half of famciclovir is more than 8 hours, and it is having very good oral bioavailability. It can be used alternative to acyclovir, but it is not useful in acyclovir resistant resistance, as the resistance which are resistant to acyclovir are resistant to all other cyclovir and cyclovir, very insignificant ADRs. Then comes Acyclovir. The good thing about Acyclovir is it is the drug of choice of CMV retinitis treatment in immunocompromised patient. We will see that. So it is actually analog of acyclovir. All the drugs, all the cyclovirs are actually analogs of acyclovir, and acyclovir is the prototype drug. So it is active in CMV because there is a disadvantage of acyclovir that it is not able to cover CMV infection. So we made these Acyclovir, the analog of acyclovir, in lab to cover CMV as well. Its bioavailability is 10%, so Acyclovir has been made just like Acyclovir, whose bioavailability increases from 10 to 60. Then T-half is 2 to 4 plasma, again very frequently need to be given. But in CNV infected cell, the T-half is more than 24. This is very, very good thing. So the dose frequency is reduced in CNV infected cell. So that is why it is a choice of drug for CNV infection. There are bone marrow toxicity has been seen with Acyclovir, and other ADRs are fever, rash, nausea, neuropsychiatric disturbances. It is teratogenic and carcinogenic, so it is should be avoided in pregnant patient where we use the drug which are safe, like acyclovir, if it is at all efficacious. Then drug interaction are there with Acyclovir, like zidovudine, which is antiretroviral therapy. We'll see that also causes bone marrow suppression, and Acyclovir also causes bone marrow suppression. So together they will add up the ADR of myelosuppression. With cyclosporin, obviously, because cyclosporin is nephrotoxic, and Acyclovir is also having some nephrotoxic potential, so there will be addition of that toxicity. And because of this only, because of these toxicity, so इसका use बहुत limited हो गया. Now we are using the newer drugs, but still Acyclovir is the drug of choice for CMV retinitis in immunocompromised patients. So now comes to Tenofovir, the another group of drug, cyclovir and cyclovir group of drug. You see, dependent on the thymidine kinase of virus, but if there is resistance developed to those, we have this drug Tenofovir, which is not required viral thymidine kinase for its activation. So many acyclovir and Acyclovir resistant viruses are still susceptible to the Tenofovir. You can see here the same picture which I already show you here, this group of drug which is helpful in treatment of those viral infections which are resistant to this group of drug, because these are no more dependent on the viral specified enzyme. Okay, so you can see here the Tenofovir diphosphate is the active form of Tenofovir. Again, the antiviral drugs almost all are having poor oral absorption, so used parenterally here. And this is that the probenecid, which is very, very important in penicillins also, because it increases the efficacy and duration of action of penicillin. It is also useful in treatment of herpes along with Tenofovir. So Tenofovir probenecid interaction is positive interaction where it improves the availability of Tenofovir and reduces the adverse effect. T-half of Tenofovir is 3 hours, but intercellular it is long. Weekly therapy is required. So this is one very good example of drugs. If somebody says that, give example of the drug whose T-half is very less, but the drug regimen is very infrequent. Like Tenofovir T-half is 3 hours, which means that we need to repeat it again and again like acyclovir. But still we are giving weekly therapy just because they remains accumulated. Because of very good volume of distribution, they very get accumulated, and tissue binding is very high. So it binds to the target tissue and remain intracellularly CMV infected cell for very a long time, or any herpes virus infected cell for very long time, which leads to decrease its frequency of treatment, and only weekly drug is given. And it is after Acyclovir, it is second choice in CMV and immunocompromised patients. So Acyclovir first choice, Tenofovir second choice. Apart from that, it causes ADR, which is common with other antiviral agents also, like nephrotoxicity, gastric disturbance, hypersensitivity, neutropenia, and uveitis. Postcarnate is the phosphonate, which is not related to nucleic acid precursor. So far we have seen the drugs which we are discussing are the nucleic acid precursors, like either they are precursor of adenine or guanine or cytidine and thymidine, but foscarnet is the only anti-herpes drug which is not related to nucleic acid. Its mechanism of action is totally different. And because they are not related to the nucleic acid precursor, they can be useful in the treatment of those viral infections which are resistant to the nucleic acid precursor drugs like acyclovir and acyclovir. Its oral absorption is poor and T-half is less, and it is not metabolized, it excreted and changed. ADR, they are quite toxic drugs, like they cause nephrotoxicity like other antiviral agents, but more. And apart from that, anemia, phlebitis, because parenterally we use it, and tremor convulsion can happen. Then come idoxuridine and trifluridine, which are only used for herpes simplex keratitis and only available as ophthalmic solution. And they are only active against DNA viruses. They are not active against RNA virus. Can you tell me why? Because they are thymidine analog, right? Which is not there in RNA viruses. Very simple. So they are only active in DNA viruses. Acts faster than acyclovir eye drops, and ocular irritation can occur. Another, the same thing, trifluridine, which is the fluorinated nucleoside of it is fluorinated idoxuridine actually, the fluorinated triflu. So if you fluorinate some drug, it will become fluorinated molecules, and the efficacy is increased. Then come Fomivirsen, which is 21 base phosphorothioate oligonucleotide, and it provides antisense therapy. So, what is exactly the mechanism of Fomivirsen? The first line you need not to remember. The second line is saying the mechanism of action of Fomivirsen. So, it binds to the mRNA and inhibits the synthesis of very immediate early protein needed for viral replication. So if you see there is a transcription, then translation. So DNA to RNA, RNA to the protein. So this, in this part, there is first synthesis of early protein, and then these early protein is divided into some into structural protein, some into regulatory protein, and then they convert into the final proteins which are required for the viral replication. So Fomivirsen is actually binding to the mRNA and inhibiting synthesis of immediate early proteins. सबसे कम resistance Fomivirsen का है because it is working by different mechanism, and it is active against CMV, strain resistant to acyclovir, foscarnet, Tenofovir. For all the resistant, for the virus which is resistant to all the available drugs, Fomivirsen is the drug of choice. Fomivirsen is given by intravitreal injection treatment of CMV. This is what we have seen in that table, that it is available as intravitreal injection. Now comes anti-influenza drugs. So this is all about anti-herpes drug. I hope you understood what I want to tell you, that you just focus on that table and the mechanism of action, which is very, very simple. Nothing is happening. Just in place of the normal nucleoside analog, we are incorporating the lab-made nucleoside, which is competitively antagonizing the enzyme viral DNA polymerase, and hence there is killing of the virus, DNA-dependent virus. Now, anti-influenza virus, there are 5 drugs: Amantidine, Amantidine, Oseltamivir, Tenofovir, Peramivir. You can see the second column of dosage form where Amantidine, Amantidine, and Oseltamivir are orally available. That means they can be given by oral route. But Tenofovir is the drug which is not available because of very, very less bioavailability, which you can see in the third column. So because there is very less bioavailability, it has been made to take administered by intranasal route. So you need to remember which anti-influenza drug is taken by intranasal route. It is Tenofovir, and reason is because of less bioavailability. Similarly, Peramivir bioavailability is very less, so it is given parenterally. So the drug which is given parenterally, anti-influenza drug, Peramivir; the anti-influenza drug given by nasal route, Tenofovir; and rest of the drug like Amantadine, Amantadine, and Oseltamivir is taken by oral route because they are having very good bioavailability of more than 80%. Plasma protein binding is different. You can see Amantadine has maximum. You'll see that. Then T-half is varying from 12 to 36 hours in case of orally available anti-influenza drugs, and very less for zanamivir because obviously it is taken by intranasal route, so it will degrade very soon from the superficial mucosa by the local enzymes. And then there is one more thing is metabolism. So amantadine is metabolized in liver, amantadine very less than 10. So they all are excreted unchanged in urine, leads to the neurotoxicity and nephrotoxicity. Now here comes the use. So there are two types of influenza, influenza A, influenza B. The first three drugs are helpful in treatment of only influenza type A. But later on, these new drugs has been made like Oseltamivir, Zanamivir, Peramivir, which can be used to treat both influenza A as well as influenza B, right? So again, if you go in deep in mechanism of action of anti-influenza virus, it is totally different than that of anti-herpes virus. You will find anti-hepatitis and anti-herpes having same mechanism of action, but anti-influenza virus drug are having very different mechanism of action. First, you need to see the life cycle of influenza virus in the human cells, like there, and then there is endocytosis, which is, and after that, there is one ion channel. M2 protein is one ion channel which give entry to the H positive proton. So it decreases the pH inside, and there is then release of this virus, which we say uncoating. This uncoating is inhibited by amantadine and amantadine, which is the first two drugs in that table. So amantadine and amantadine are acting by inhibiting the M2 protein, which is the ion channel, which allow the entry of H positive ion and responsible for uncoating. Without uncoating, virus will not enter into the nucleus of the host cell. It will not replicate. It will not translate and transcribe. And the other rest of the three drugs, what they are doing is their mechanism is here at the last, where there is a release of virus from the host cell. Here, Zanamivir, Peramivir, and Oseltamivir, the name is same. You can see the surname. Here it is Antidine, or you can say Mantidine, Amantidine, Remantidine. These are here inhibiting M2 protein, like, but the Mivir class or Amivir class, like Zanamivir, Oseltamivir, Peramivir, they are inhibitor of the release. We'll see that how it happens. And here comes the amantadine and amantadine. If you see, they are, I already discussed, they are inhibiting the M2 protein, which is responsible for entry of H positive, reduction in pH and in the endosome, and very uncoating of the virus inside the host cell. Of the ADR of amantadine, need to remember, like minor dose related ADRs and high plasma concentration. If there is high plasma concentration, so minor dose related ADRs are CNS and GI effects. GI, you all know, nausea, vomiting, loss of appetite like conditions, and CNS, nervousness, lightheadedness, difficulty, not nothing serious. But if there is a high plasma concentration inside the patient, like because of some metabolic issues, it will lead to serious neurotoxic reactions. Like here, you can see the very minor dose related CNS action, but if the plasma concentration is high, they are very, very neurotoxic. It will lead to delirium, hallucinations, seizure, coma, cardiac arrhythmia as well. So remantadine is introduced as the methyl derivative of amantadine, and it is very, very uh, effective. That 4 to 10 times more active than amantadine, and it is longer acting than amantadine, and it is better tolerated than amantadine. That is, the ADR is less. So see, amantadine is just an analog or derivative of amantadine with a few advantages of better efficacy, less side effect, and longer action. Now come oseltamivir carboxylate, which is a sialic acid analog, and there is another salt of oseltamivir, which is oseltamivir phosphate, which is ethyl ester product that lacks antiviral activity. So we use oseltamivir Okay, I am audible now. So, yes, Oseltamivir we are discussing. The mechanism of action is very simple. That this salt of Oseltamivir, that is Oseltamivir carboxylate, is am I audible now? Yes, I am audible now. I can see that. So, yeah. Okay, Shashwat, now I am audible. I can see that. So let's continue. So this is about the mechanism of action of oseltamivir. So Mivir group of drug acts by this mechanism by inhibiting the release of virus, right? By inhibiting the enzyme neuraminidase. And the that group of drug amantidine and remantidine, they are act by inhibiting the M2 ion channel. These two things you need to remember. Then there are these drugs Zenamivir and Peramivir. As we know, Zenamivir is used by intranasal route because of its poor bioavailability. This is what you need to remember, and because it is taken by intranasal route, most of the drugs which are taken by intranasal route they leads to wheezing and bronchospasm, and Zenamivir is contraindicated in asthma, and it is not available actually in our country. Peramivir is another drug which is a good thing about it, that the single 600 mg dose administration via IV route is uh, over 50 to 30 minutes is sufficient to treat influenza virus infection single dose. And the most common adverse event is diarrhea with Peramivir, and there are some hypersensitivity reaction has been seen like Steven Johnson syndrome, erythema multiforme, and there is increased risk of neuropsychiatric events such as hallucination, delirium, and abnormal with Peramivir. So you need to remember this two group of drug in influenza. Like one is amantadine group, and another one is Mivir group. That is Oseltamivir, Peramivir, Zanamivir. The difference is that Oseltamivir can be given by oral route, Peramivir and Zanamivir given by intranasal and IV route. Uh, and the mechanism of action is different for Mivir group and Amantidine group. These five drugs are available for treatment of influenza. So this is all about the influenza virus infection. So two group of drug we have seen so far, herpes and influenza. So you must know the microbiology of all the virus, which is RNA virus, which is DNA virus, what are the diseases that they can cause, what is the life cycle of these viruses, what are the various steps where the target or their potential target for the pharmacotherapy, then only you are able to understand the pharmacology, which I am discussing right now. Now, hepatitis virus, again, as a topic from microbiology, it is very important to know all the families of hepatitis virus from A to E. And you must know that hepatitis virus is called as hepatitis because it leads to inflammation and necrosis of liver. The name suggests it's this action suggests the name itself. So hepatitis is inflammation of hepatic cells caused by virus. So we call it hepatitis virus. Out of all A, B, C, D, E, A and E are typically self-limiting and the oral route से ये mostly होते हैं, and there is no antiviral therapy is required for their treatment. Only the treatment of dehydration by oral rehydration solution and parenteral rehydration can be done. And the only drug available to treat hepatitis D, which is not a independent entity, D always happen with B as a super infection to hepatitis B. This you all need to remember and read from microbiology. So for that super infection B with D, the only available drug right now with us is pegylated interferon alpha. We'll see what is pegylation, what is interferon. Hepatitis B virus is a vaccine preventable illness, whereas there is no vaccine available to prevent hepatitis C virus. So A और E का हमने बात की कि कोई antiviral agent नहीं चाहिए. B, C, D में D is not independent. It always comes with B. And if it comes with B, the only treatment left is pegylated interferon. बचे दो B and C, hepatitis B virus and hepatitis C virus. One is vaccine preventable disease. So we have vaccine to prevent hepatitis virus, but unfortunately we have very limited drugs to treat hepatitis B virus if it happens. On the other hand, we do not have vaccine to a very effective vaccine to prevent hepatitis C virus, but we have very good treatment now to treat hepatitis C virus. So this is the difference between B and C. So it is better to prevent B virus because we have very limited drugs to treat B, hepatitis B virus. While for SCV there is no such problem, we have very good drugs to treat it. Completely curative treatment. Now here comes the again I am telling you from microbiology book, you need to read this life cycle thoroughly. Here again the everything is same. The little bit of in-depth wisdom about the mechanism of action and life cycle of hepatitis B virus is required here. Like the receptor binding first, which leads to uncoating and just similar to the influenza virus we saw. Hepatitis B virus is a DNA virus. Now here there is a covalently means what is happening. This it enters into the host cell where there is nuclear transport of relaxed circular DNA and there is formation of covalently closed circular DNA. This is triple C DNA is there in hepatitis B virus. That's why it is very difficult to treat. Now this covalently closed circular DNA transcribed, okay, and after transcription it exports outside and translated in the ribosome because translation happens in the ribosome, and then encapsulation occurs, reverse transcription. Reverse transcription means RNA to DNA, and then there is DNA synthesis, and then there is packaging and release. So this is the life cycle of hepatitis B virus. So these are the drugs. So you can see here very limited number of drugs we have. As we said, there is a vaccine, good vaccine for hepatitis B virus prevention, but the curative therapy is limited. So it's better to prevent the infection with hepatitis B virus. So these drugs you can see here, and rest of the thing are as same as that of herpes. So we are not going to discuss it. They are analog. They are DNA. It is a DNA virus like herpes. It is the lab-made analogs are there like Telbivudine, which is analog of thymidine, lamivudine, cytidine, then Adifovir and Tenofovir for adenosine, and Anticavir for gynosine. Now these analog as similar to that drug which we discussed in anti-herpes. These nucleoside and nucleotide analogs get converted to their monophosphate and diphosphate form by using host cell kinase, and then their diphosphate and triphosphate form are active, and which do this, which we already seen that they competitively inhibit the DNA polymerase enzyme, which is required for synthesis of DNA of the virus, and also they get incorporated into the proviral DNA, and there is a faulty detection of the chain because in place of the normal nucleoside, these lab-made nucleo analog has been there, and there is a termination of chain elongation, and there will be no further replication. So if we come to the drug lamivudine, you can see it is useful in both hepatitis B virus as well as HIV. So we will see that And lamivudine resistance is very common nowadays. 70% of the patient develop lamivudine resistance. So now we have many more drugs to use. Otherwise, lamivudine was very popular drug against these kind of viral infections. So if you see the pharmacokinetic, a very good bioavailability has been noted. So oral treatment with lamivudine is sufficient. Then T half is plasma T half is 6 to 8 hours, and intercellular is mostly more than 12 hours. So most of the antiviral drugs act that way, that the infected cell they get accumulated and their uh, intracellular concentration remains high for many hours, but plasma concentration reduces to 6 to 8 hours. It excreted and change in urine to nephrotoxic, and it leads to ADR like very normal, like headache, fatigue, rash, nausea, vomiting. Very well tolerated, just like other drugs like acyclovir is very well tolerated anti-herpes drug. Similarly, lamivudine is very well tolerated anti-hepatitis drug, but it can cause pancreatitis and neuropathy, which are rare, but they are peculiar side effects with lamivudine. So it should not be added in the regimen with any other drug which are also having the same side effect like pancreatitis and neuropathy. So Antigavir is another group of drugs which the good thing about it is that we know that there is a food drug interaction. So again, somebody asked many times, it has been asked about drug interaction, food drug to drug interaction and drug to food interaction. So it is very easy to understand and remember few names, like if you remember in malaria we said lumefantrine absorption increases with dairy. So here fatty food. So here Antigavir food absorption decreases with the food, so it should be taken empty stomach. So these few example you can quote every time somebody asks about the drug interactions. Then it is also excreted and change in urine, which leads to nephrotoxicity. T half is very high, very well tolerated drug. It is also very well tolerated drug. Apart from very less severe side effect like nausea, vomiting, diarrhea, dyspepsia, fatigue, it causes rarely but a very severe side effect called lactic acidosis, but very rare with anticavir. Then come adifovir, dipivoxil, which is the salt of adifovir, and this adifovir is least active nucleotide analog against hepatitis B virus. So amongst all the drugs like lamivudine and the drugs which we see, adifovir is less effective, and it is only reserved for the chronic cases which is having lamivudine resistances because it is less effective. The esterases enzyme in liver and intestine releases the active drug, so they are also prodrug. This adiphobic dipipoxil is a salt which get activated in the liver by esterase, and the availability is good, 60%, and plasma T half to 7 hour, intercellular is 18 hours. So low dose may it is very well tolerated and lead to very few side effects like sore throat, headache, weakness. But in higher dose, it can cause nephrotoxicity as it goes outside unchanged. Then comes tenofovir, disoproxil fumarate (TDF). It is again a salt of tenofovir, which is a nucleotide analog, basically not a nucleoside analog. It is a nucleotide analog. So there is a minor difference between these two, hepatitis B virus and hepatitis. So if you remember tenofovir, lamivudine, they are not only useful in hepatitis B virus infection, they can also be used in treatment of hepatitis herpes, human immunodeficiency virus. Rather, tenofovir are the first line drug nowadays. It leads to adequate oral absorption. T half is high. Tolerability is good with these drugs like adifovir, tenofovir, acyclovir, but some GI toxicity, GI upset can happen, and there is acute renal injury, but very rare, but it can happen with tenofovir. So then we come to telbivudine. So telbivudine is another drug which we can use for treatment of hepatitis B virus, and it is latest entry in this classification. It is absorbed orally, and the bioavailability is not affected by food, which is good thing. So there is no such advice to the patient is required to given that it should be taken with food or without food. It excreted unchanged in urine. T half is high, 15 hours, and tolerability is good. All the drugs with anti-hepatitis B virus uh, action are having very good tolerability. but some GI toxicity can seen: abdominal pain, diarrhea, cough, headache, myalgia, which you all know. Then comes hepatitis C virus. We will see it after a break. Let's take a break of 30 minutes for lunch. Okay. After 30 minutes at 1:30 p.m.,